Okay, so we're going to cover Chapter 17, Elimination. So elimination, it can be a really big issue, and it can interfere with with your body's ability to be independent, and it threatens the capacity to function. So it also can really take away someone's independence and well-being. So we're going to talk about some of the age-related things that happen in the renal system, in the urological system. One is there's a loss of nephrons. The kidney mass decreases, and then the body's ability to concentrate urine leads to a little change in the body's ability to maintain adequate fluid homeostasis. Renal disease, we talked about kidney disease can be more common in the elderly, or urinary tract obstructions can make decline in function worse. Urinary incontinence and urinary frequency should not be considered a normal part of aging. It does happen a lot with the aging adult, but it's not an inevitable part of aging. Urinary. So talking about urinary incontinence, there's definitely a stigma to it. It is underreported and underdiagnosed. People don't seek treatment for it because they think it's just a normal part of aging, or they might be embarrassed and don't want to talk about it. So it is often viewed as an inconvenience instead of a treatable condition. So nurses can really help to promote education around urinary incontinence. So just some facts and figures. Urinary incontinence affects millions of adults worldwide. There's over 25 million Americans who live with some kind of bladder leakage. It is more common in women, especially around menopause, and then it is increasing in men as well. It's more prevalent than both diabetes and Alzheimer's, and more expensive than diabetes, because if you think about the supplies that you have to buy to, like, pads or briefs to try to prevent or try to help with incontinence, it gets very expensive. Risk factors. What are the risk factors for urinary incontinence? There's risk factors associated with different changes in aging. Dementia is a really high risk factor for urinary incontinence because the person may not be able to find the bathroom, or they may not recognize that they have to go to the bathroom. Drugs that increase urine output are also a risk factor for urinary incontinence. So you look at that's some of your diuretics, some of your sedatives, hypnotics, drugs that make you confused or drowsy, and those can make incontinence worse. Other risk factors for incontinence: smoking is a risk factor, obesity because of the pressure that the stomach puts on the bladder, constipation, and there's a close correlation between constipation and urinary incontinence. So when someone is incontinent, you definitely want to ask about their bowel habits, because if you can correct the bowel habits and the constipation, you can greatly help improve the urinary incontinence. Comorbid conditions like diabetes and Parkinson's disease definitely are risk factors for incontinence. Pelvic muscle weakness and depression. Some of the consequences of urinary incontinence: it definitely affects the quality of life, psychosocial, economic, and physical. There's all of those consequences. It is associated, there is an increased risk of falls, which leads to an increased risk of fractures and hospitalization. It does affect self-esteem. It increases risk for depression and anxiety. It also decreases, it takes away some dignity from the person, can cause social isolation, skin breakdown, and then a disruption in sexual activity. It increases the risk for admission to the nursing home in those over 65 years of age. If you're incontinent, you're more likely to need to be in a nursing home. And then psychosocially, it affects the person and their caregivers. So it's quite a big problem that we need to be addressing. There's different types of urinary incontinence, and hopefully you've studied this a little bit. But you either have acute or chronic urinary incontinence, or there's transient. So transient has a sudden onset. It's been present for 6 months or less, and is usually caused by treatable factors like stool impaction, constipation, increased urine production. So those are transient causes of urinary incontinence, and hopefully those will come and go. But the established urinary incontinence, there's 5 different types. So there's stress incontinence, and stress incontinence is where you cough or sneeze and have urine leakage. Urge incontinence, and that's where when you have to go to the bathroom, all of a sudden you have to go right now, and you have that sudden urge to go to the bathroom. Overflow incontinence, and that is when there's like almost a constant urine loss. So like there may be dribbling, so they've gone to the bathroom, but there's a slow urine stream, and they're passing just really small volumes of urine. There's functional incontinence, and functional incontinence is where some external factor is keeping them from going to the bathroom. So maybe they can't get the button on their pants undone. Maybe they have trouble actually sitting on a toilet. So it's some kind of functional problem that's keeping them from going to the bathroom. And then mixed is very common, and it's a combination of several types of these urinary incontinence. So if you look on page 214 in your textbook on table 17.1, there is a table that kind of discusses some of these types of urinary incontinence, which could be helpful for you. Assessment, urinary incontinence, you should be routinely addressing this with assessment. So on initial assessment and then follow-up assessments. 80% of incontinence can be cured or treated. So it's just, again, people don't talk about it, so they don't know that there is treatment for it. Assessment is multidimensional, and you want to include what their continence patterns are, alterations, contributing factors. And then there's a continence assessment. It's on page 215, and there's different questions that you can ask. So, for example, you want a screening question is, have you ever leaked water or urine, and how much does it bother you? Do you ever have to wear pads, tissues, or cloths in your underwear? Do you have any burning or hesitancy or pain with urination? And then it goes through different types of assessment. So asking about bowel patterns, asking about how much fluid intake they've had, doing a medication review. So I'd like for you to just take a minute and look over that and see what some of the different pieces of assessment are for this. Interventions, if you look on box 17.6, there's some interventions for best practice, but one is use therapeutic communication skills and positive and supportive attitude, share helpful resources, share techniques found useful by others, come up with an evaluation plan to assess this. So you can take a look at that box on 17.6. Lifestyle interventions, there's lifestyle interventions, environmental and behavioral interventions, and one of the things that I want to point out is the scheduled voiding. So this is used, in your textbook says it's used in cognitively intact and people with cognitive impairment, but this is where you set up different times to go to the bathroom, and you schedule that, and you say, okay, you're going to go to the bathroom now and in 2 hours, and then you're going to have set times. Or for example, when you get up, when you get up in the morning, you're going to go to the bathroom, when you go to meals, you're going to go to the bathroom, and that can really help them. Having a set time, the body kind of gets used to that time. So having a set time where they void. Pelvic floor muscle exercises, and we'll talk about this a little bit later, but this is on page 218, box 17.7. The pelvic floor muscle exercises are really important. They're also called Kegel exercises, and they are for both men and women. And basically, and we'll go through the steps here, but you start by going to the bathroom. You can sit up, you can lay down, you can do this anywhere, and you tighten the pelvic floor muscles and hold for about 10 seconds. Relax the muscles and count to 10, and then you contract the muscles again. So you do 10 repetitions 3 to 5 times a day. Something that can be helpful, like if you're having someone who's struggling with how to do this, is you tell them, like if they sit on the toilet and they start a urine stream and then they constrict it and stop the urine stream, those are the muscles that they want to work on contracting when they're doing Kegel muscles or Kegel exercises. And we'll talk a little bit more about this in a minute. Habit or bladder retraining. We talked about this. Frequent voiding. So this is where you want to make sure you're going to the bathroom often to keep the residual urine low, and then you want to make sure they're going frequently, like every 2 hours, and then you can gradually increase that time. So that's bladder retraining. And then prompted voiding. This is something that's an intervention that can be used in long-term care. And if you look on page 218, it's here. But this is something so you can contact the resident every 2 hours, focus the attention on whether they're wet or dry, ask them if they need to go to the bathroom, and check the clothes and the bedding to make sure that they haven't had an accident. Whether they did have an accident or not, you need to ask them if they want to use the toilet and offer to let them do that. If they say no, then you can repeat the question. If they're wet, then you can change them, and then let them know you'll be back in 2 hours. So again, it's just you're going every 2 hours. You're to ask them if they need to use the restroom. You're encouraging them to use the restroom. If they're wet, you're changing them, and so you're getting that routine down for them. So I want to show this video on Kegel exercises. It's short, but I think it will be helpful.
No one wants to pee themselves here, or anywhere. Kegel exercises can help with urinary incontinence if done properly. Hi, I'm Dr. Jason Cruff, urogynecologist with Marshfield Clinic Health System. I want to share with you how to properly perform Kegel exercises. When you perform a good, strong Kegel contraction, you use the same muscles used to hold in gas or pee. You should feel your pelvic muscles tighten and elevate toward your pubic bone to help strengthen your pelvic floor. You can perform Kegel contractions anywhere throughout your day. Once you can fire those pelvic muscles, hold the contraction for a full 5 to 10 seconds. Then, relax for 5 to 10 seconds and repeat 10 times. Perform these exercises 3 to 4 times a day. If you continue to have questions or concerns about Kegels, talk to your doctor. We're here to help.
Okay, so, and then we've already kind of talked through what's in your textbook, so you can refer back to page 218. Continence programs in long-term care settings are required by Medicare and Medicaid, and this is where you monitor and document the continence status of a resident. So some barriers to implementation and continuation of toileting programs. A big one is lack of staffing. And when we talked about prompt avoiding, we talked about the staff checking them every 2 hours and asking them every 2 hours, which takes a lot of staff. And if there's one nursing assistant and 30 residents, then it can be nearly impossible for them to do this every 2 hours. So that's a big barrier. Also, knowledge about urinary incontinence, and just not having enough professional staff is really problematic. Urinary catheters, as you know, we're trying to get away from using urinary catheters unless you absolutely have to. But there are some situations, like especially in spinal cord injuries, or something like neuropathy or neurogenic bladder for diabetics. That's where the nerves in the bladder are gone, and so they literally don't feel like they have to go to the bathroom, and the bladder can overexpand. I once took care of a patient who had 900 mils of urine in his bladder, and he didn't even it's like he didn't even know he couldn't void, and it's because he had this neurogenic bladder from diabetes. So if there's a problem like this, you can do intermittent catheterization, and this is where the patient will catheterize themselves like several times a day. So usually we see this with spinal cord injury, diabetic neuropathy, sometimes the enlarged prostate or BPH. An indwelling catheter is where the catheter stays long term, but this does increase the risk for urinary tract infections. So if the person has a lot of care needs or they're cognitively impaired, this puts them at a higher risk for needing that indwelling catheter. And then there are the condom catheters, and these are used for male patients. Urinary incontinence management, absorbent products, so like the briefs, and we don't call them diapers because that can be kind of demeaning, so we usually call them briefs. Pharmacological interventions or medication, usually we don't do this first. It's not first line treatment. We don't jump to that first, but it can be helpful. And the class of medications for this is anticholinergics and antimuscarinics. There are some surgical interventions, so especially for stress incontinence. And the most common one it's called a copal suspension or a sling. And it's where they just take the bladder and kind of tuck it back up where it goes and sew it in and keep it steady there. There are some non-surgical devices, and one of these is called like a pessary, and you can actually, like if the uterus has fallen down, you actually put this in the vagina and it keeps everything pushed up to where it needs to be. But obviously it's not a long-term solution. It can be problematic. They can fall out, and the person has to know how to use them. Urinary tract infections, this is the most common cause of bacterial sepsis in the older adult, 10 times more likely to occur in women. And this is assessment and appropriate treatment of UTIs, especially in older people in the nursing home, is really can be difficult, but you need to stay on top of it because it can turn into sepsis. The person may be cognitively impaired, or they may not have classic symptoms. And so just as an aside, and some of you may know this, but the elderly who have a urinary tract infection, they don't always present with the same symptoms as a younger person. So the urinary frequency, the pain with urination, the number one sign that an older person has some kind of urinary tract infection could be confusion. So they get confused and they're just not acting like themselves, or they have a fall. That can be a sign of urinary incontinence. So if there's behavioral changes, mood changes, like cognition status changes, you want to suspect a urinary tract infection, even if you don't have any of the other classic symptoms, and you want to check for that. The diagnosis of a symptomatic UTI is based on the lab values, like a urine dip, and also the clinical symptoms that they're having. So we're going to talk a little bit about bowel elimination. Bowel function is only mildly changed with the signs of aging, but bowel function can be very limiting and very problematic. Normal passing of stool, it should be easy, shouldn't have to strain, and you should feel like you've completely evacuated everything, all of the stool. Constipation, this is designed as the reduction in the frequency of stool or difficulty in forming or passing stool. There's the Rome criteria, which kind of outlines different definitions of constipation and can help you to classify. And I believe you guys went over this last semester, but constipation can be associated with impaired quality of life, significant healthcare costs, a large economic burden, and can definitely lead to serious consequences. And it is considered a symptom, not a disease. Fecal impaction, this is where the stool becomes kind of stuck in the rectal passageway. This is definitely more common in people who are in an institution or a long-term care facility. Also, if they're getting narcotics for chronic pain, it can cause this fecal impaction. If it's unattended or unrecognized, or if constipation is unrecognized or unattended or not taken care of, then this constipation can lead to fecal impaction. Removal of fecal impaction is a lot of times worse than just having the impaction itself. You can do a digital removal of the stool, and this is where you put your gloves on, you put some lubrication on your finger, and you put the finger into the rectum, and you have to kind of break up the stool to get that stool to pass. And it's usually very painful for the patient. And so it's kind of a miserable thing to have to do. So what are some implications for nursing? One is assessment. It's important to have a complete bowel history. So you want to ask about usual patterns, frequency, size, consistency. If there's any changes, you want to ask about straining and hard stools. And you want to know about the causes of constipation and put that in the evaluation as well. Interventions, we always start with non-pharmacological interventions. First one is just increasing physical activity. Increasing physical activity will increase peristalsis, and this will help to prevent constipation. Positioning, trying to have the person defecate in a sitting position just to have gravity help with that can be really helpful. And then getting on a routine toileting regimen. There are pharmacological or medications that can help with this. Miralax is one, milk of mag is another. Those are probably the two most common ones. There's the Go Lightly Prep that's used for colonoscopies, and some people use this and it helps to clean them out. There are enemas, and I know we've talked about that a little bit, but those can help prevent keep constipation, and then some alternative treatments. Other interventions for constipation, you want to make sure you're having adequate fluid intake, so at least 1.5 liters a day, and that should mostly be water. You want to increase the fiber. Fiber in the body helps the stool to become bulkier and softer, and then that allows that to have easier passage through the body. Physical activity, we've talked about that. Physical activity stimulates motility in the colon, and also peristalsis increases, which helps to promote a healthy bowel. And then aluminum hydroxide antacids are known to be constipating, so you want to stay away from some of those antacids. Fecal incontinence. This is a problem, and just like urinary incontinence can be embarrassing and people don't want to admit it, the same thing happens with fecal incontinence. So fecal incontinence is an involuntary loss of liquids or soft stool. And so it's definitely a social and a hygienic problem. This happens more in people with diabetes, irritable bowel syndrome, someone who's had a stroke, multiple sclerosis, or spinal cord injury. Fecal incontinence is also associated with urinary incontinence, and it can be very, very devastating, very isolating for the person. And it's now that I've been saying fecal incontinence, the actual term, the accidental bowel leakage, that's preferred over using fecal incontinence, just so that there's not a stigma. Assessment, you want to include complete client history. You want to include the stool consistency, stool frequency. You want to include if they have to use any medications, laxatives, or enemas. They do a physical examination, paying special attention to the GI system. Some other interventions for promoting healthy aging, making sure that you manipulate the environment to make them successful for not being incontinent. So making sure the toilet is accessible. Maybe they need a bedside commode. Making sure the path to the toilet is clear. Altering their diet, increasing fiber, increasing liquid intake. The habit training schedule that we talked about, avoiding on a schedule. The Kegel exercises or the pelvic floor muscle exercises. And this helps with not only urinary incontinence, but also helps with stool incontinence as well. Improving their ability to transfer and ambulate. Doing sphincter. And there are Kegel exercises, there are rectal sphincter training exercises where you can actually train the sphincter and do exercises of the sphincter to make bowel incontinence less likely. Biofeedback, if you go to a GI doctor's, they can actually, just like you do biofeedback for the Kegel exercises, they can actually, hook you up to sensors, and you can look on a screen, and as you're contracting those muscles, you can see that on the screen, and it shows you that, yes, you're contracting the right muscles or you're doing the exercise correctly. Of course, medications if need be, and then there are some surgical options as well. So question is, which is a risk factor for urinary incontinence? High caffeine intake, smoking, or estrogen deficiency? And the answer is D, all of the above. And which persons have the highest risk for fecal incontinence? And it is people that are living in nursing homes. So please make sure you read over this chapter 17, and do see the Canvas page for any activities that go along with this. Thank you.